So, just 2 minutes on, or 2 slides, on why we're doing research on breast cancer risk, since, as you've already heard this morning, we know a lot, but we don't know everything. And then to talk about one other study. So, obviously, there's still a lot more to learn about how breast cancer arises and even why there's so much breast cancer. We don't even know all the genes that can increase risk. You heard Brittany talk about 10 genes we know, but we always have families who look like something should be inherited, but we don't find anything when we look. We have pretty good data now, after all these years of looking, on estimating risk. You've seen curves and percentages and numbers, but actually we're not that good at individually telling you your risk, so we can't tell you which 5 years to take tamoxifen if you're willing to take it, or exactly when to be worried, should you think about surgery. Exactly, we can just help you think about probability and how to shift it around, and that is a struggle, so don't feel bad if it's a little overwhelming. But so not only do we need to get better at the estimates, but better at explaining the estimates. We have good ways of detecting early breast cancer, and Dr. Lehman's going to tell you about real progress in that area. But I think we'd all be happy to have better ways. And some of those ways are not just with imaging, but people are looking at blood tests to see, with our enhanced technologies, could you find very early evidence of breast cancer even before mammograms could see it? And that's a challenge, but maybe less important in breast than in diseases like ovarian or pancreatic cancers, where we have really nothing that helps us find things too early. And I shouldn't say that, because we're getting better, but still very difficult ways. And we are better and better at estimating risk. You come to BPREP and you get much more sophisticated estimates than we ever could do before, and much better ways of explaining risk. But when it comes to risk reduction, how do we help that in ways that will be acceptable as well as effective? Because we have effective ways, but it's very hard to get people to want to do them. So one study that I just wanted to mention, even though it's not an intervention study, is the SEARCH study. So for any of you who have been to the clinic in the more recent period of its life, I think almost everybody's now invited to be part of the SEARCH study. And it includes permission to use the risk factor questionnaire that you fill out, and any imaging data that you have, pathology data, for research as well as for clinical care. So when you come and fill out that form, your understanding is that it's being used for your care, and that's correct. And in order to be able to use it for research too, we have to get your permission. So people will ask you to do that. We do ask for blood samples, and the blood samples are for this early detection projects, but also to look at other risk factors. So people have measured over time things like blood lipids that you measure for a heart attack risk, or tumor markers. None of them works very well for breast cancer risk, but there are a lot of ideas for things that might be better. So these samples are collected, and some of them will be used over time as markers get better. Also, as with time we get to see were they really predictive or not. So we will ask if you would sign an informed consent document. And so, as I said, we would never use your material, even your risk factor data, without your consent. And you can withdraw consent, so research is optional, and there are lots of language about that in the consent form that the team will show to you. And then there are many layers of privacy protection. So if your worry is that you would say yes to research and you'd find yourself on the front page of the Globe, that really does not happen. But neither can we guarantee that there aren't hackers out there who, if they really want to know whether you have mammographic density, couldn't figure it out. So I can't guarantee, but we have a lot, and we can tell you about what the protections are. So we feel comfortable asking for you to do this. Research is always not just our ideas, but approved by the institutional review board. We have to convince them scientifically and by the human subjects aspect of the work that this is okay, so you can be confident that these things have at least passed several layers of review before we ask you. And with all that said, you still always have the right to say no or to change your mind even if you've said yes before. So I'm going to talk about another study that's also based on mammographic density, and I want to make sure that you don't get confused that Dr. King tried to help us all have a more balanced view of mammographic density than you might get from those letters that make it sound like you have a disease. Mammographic density is just a measure, and not only that, mammographic density can change. And the reason that we have all these studies looking at mammographic density is not because we all love mammographic density, which I don't know about Connie, but the rest of us do not, but because it can change. And so if you are interested in lowering breast cancer risk and you can show that whatever intervention, exercise, diet, medications can lower mammographic density, then you feel encouraged that maybe this actually could lower risk overall. The most things that lower density are things like menopause, where estrogens get lower, then a lot of people's density changes. Or medications that do lower risk, like tamoxifen, can also be shown to lower mammographic density when it's effective. And so we try to use the model as what we call a biomarker, just a way of trying to see, are we at least on the right track? Because prevention trials, when they're definitive, take many years and many thousands of women. And this is just a way to say, are we at least in the right direction with this that we're looking at? So here, the study is called the TAMGEL study. It's a national study, it's a multi-center study that's being done to see, can we take tamoxifen, which is a drug that's been shown to reduce breast cancer risk. If you've been to clinic with one of these lesions, chances are somebody's talked to you about it. We have 20 years worth of data almost in tamoxifen for prevention. Lowers risk with a long benefit. It lasts 20 years. It's a great effect after you stop taking the drug. Great drug, works, but nobody wants to take it. Why don't they want to take it? Because it has side effects. So there are now studies asking, can we find another way to give tamoxifen that doesn't have the side effects but still has the benefit? And one of them is a study we're doing with TAMGEL. So we said mammographic density is a risk factor. Treatment and prevention show that we can change density, and that fewer than 20% of women who should be given to taking tamoxifen for their high-risk lesions or their family history are willing to do it. So let's see. And there have been studies using TAMGEL before. So who's eligible for this study? Women 40 to 55 or even younger than 40 if they have other breast cancer risk factors too. And you have to have dense breasts as read on your mammogram by the radiologist. And it's the same thing that Terry showed you, that the last two figures, the denser ones, are the ones that would be eligible, the less dense breasts, not so much. So you could not be in this study if you have had breast cancer before or even DCIS, and if in the last 3 years you've had another kind of cancer. We don't want to cause any trouble. And non-melanoma skin cancer is just like basal cells, little stuff. So the study is over a year or two, in which we first look at the mammogram, figure out if you have density, and then make sure by eligibility that you're healthy and otherwise appropriate for the study. And then the study's randomized, so it's looking at tamoxifen as a gel versus a placebo gel. So that way neither you nor we know which one you're getting. Most of the follow-up's on the phone. That's Libby in the back of the room, that she would be the one calling to ask if you're having any side effects. You don't have to come in to get tested. But otherwise, since you are coming in to get evaluated in general, we would see you when you're here at 6 months and a year. At the end of the year, you come off, and at the next year, we look at the mammogram again to see if the density's gone up or down. So I'm not sure about you. I thought this might be a little weird, but it turns out that people are willing to do this. That the density, the material, which Libby has an example of in the back if you're interested, it's really like Purell. So you could never do a study like this, if this stuff had any smell or didn't feel good or was oily or stained your clothes or your night clothes or any of this. So they've managed to make this in a substance that really is, I think, more like Purell than anything else. And we teach you how to put it on. You have to be willing to do it twice, one on each breast during the day, morning, after your shower. Do not shower it off. And then you can do it at night instead if you prefer. It is true that if you're somebody who travels all the time, this can be a little challenging, but there is actually a travel size canister, so they've taken that into account. And so this is a study, just like the exercise study, but this with a compound that has certainly been shown to work. And you might ask, if you put this on your skin, how do you know it actually gets into the breast? Because it's got to be absorbed all the way in if it's going to do its job. And that's what some of the earlier studies did. Fortunately, we don't have to do that part, where people did the surgery, did the gel before they went to surgery, and at the time of surgery, they sampled the tissue in the breast and could show that tamoxifen actually was absorbed all the way in, so it has a chance of working. So that's all. Just to let you know that the clinic is interested in making a difference, not just for each of you, but for women in general. Thanks.